Okay, we're going to go ahead and start the panel discussion here. A few housekeeping notes. People have been asking about the availability of the slide presentations. And I think you all have your agenda. If you turn the agenda open to the last page, it says Sunday, February 4th on it. There is a link there that you can type into your browser. And probably come Monday, we'll have most of the presentations available for you there to look at. We've been informed that the parking registration tickets that you were given in the morning have not been validated. You're going to have to get some new parking validation that's at the desk on as you go out the door here. So make sure if you did park here that you get the validated parking form from them so that you can make sure you can get out of the parking lot. We don't want you stuck in there. We have an additional provider in the pain ecosphere that we want to introduce today. His name is Carl Hake, and Carl comes to us from right on the border of Kansas and Missouri, where he practices as a anesthesiologist and pain fellowship trained pain specialist. And he has actually been doing a lot of work with our parent corporation, Centene, for quite some time. And throughout Kansas, Missouri, Wisconsin, Nebraska, does that cover it? Florida, yeah. And he also has been running an echo for chronic pain for, I believe, one of the longest running ones, 3 or 4 years, and serving Kansas and Missouri, successful. In fact, I was able to listen in on one of their sessions, and they had about 60 people calling in, which may be close to a record for echo sessions, but very well run. They have the pain side covered by Carl and his team, and the psychiatry addiction side covered by Sosamolo Shoyenka, who's here. If you could raise your hand. Amazing physician, amazing man. Get to know Sosamolo if you get a chance to. So we wanted to give a chance to have that echo experience, then sit up here with the other physicians who have been running pain echoes and be able to have an exchange of ideas, of best practices, of where the barriers were, where are the stumbling blocks, especially for those that are thinking about starting academic hubs or FQHC hubs for echo, and then also for the spokes, for you in the audience who you will be thinking of yourselves more as the spokes too. So with that, you know the other faces here, Dr. David Copenhaver from UC Davis, Dr. Bennett Davis from Arizona, and Dr. Anderson, who just presented. So let's start off with, if you could, what are some of the things that you have learned during the day here that really was something that you hadn't applied within your own echo sessions that maybe could be a best practice that could be shared amongst the way you're doing things now? Have you thought about that? Maybe, Darren, do you want to start off?
Is this on? Yeah. Well, I think one of the things that I've heard repeated over and over again is, well, it's reinforced and I think even augmented my sense of urgency to teach, train, and support primary care practices in the behavioral component of pain. Not to say that we haven't already incorporated that, it's a core part of ECHO, but when you're a primary care provider and you're told and you hear the message, this is coming from childhood trauma, and your approach is not opioids, it's probably not physical therapy, it's a completely different approach. A lot of times a provider is left saying, well, great, now what do I do? Because if we're not expert in pain management, we're even less expert in managing issues of childhood trauma. And so I think we need to go back and rethink how we help primary care practices tackle those challenges, the behavioral health challenges that come up as part of pain care. And I've said from the beginning of my talk that primary care needs to become expert in this, but they have to do it with an integrated approach that involves behavioral health. We're lucky enough in Connecticut to have a very large behavioral health team. We have pain psychologists, they do pain groups, they do individual CBT, they're expert in trauma-informed therapy. Not every clinic has that or has the ability to do that, so we need to think about how we can coach and support primary care practices to identify those issues and how to help them identify potential approaches to manage those issues as they come up.
Yeah, Bennett, I don't know if you've got anything to add since you're in the same group, but Carl, maybe if you want to take a crack at that.
Well, I'm amazed about how similar all the echoes are, and that's kind of reassuring to me doing ours, because we're just in this state of Missouri essentially, and with some participants in Kansas side as well. But we're essentially doing the same types of things, and that's the biggest thing that we hear is many times we have a psychologist, clinical psychologist on our ECHO team, and we make that recommendation all the time about childhood trauma, and the primary care docs are, well, just what you said. And but one of the things our clinical psychologist has said repeatedly is, as a primary care physician, just asking the question begins therapy. And that's, I know I used to be afraid to ask those questions about behavioral health, but the more I did it, the more comfortable I got. And so what we want to try to do with as part of our team, with our clinical psychologist, is address a lot of those behavioral health issues, because they're so closely tied to all of the pain complaints. And my personal view is that the use of opioids just makes all that stuff much worse. So kind of getting to the heart of that matter. So,
David, you want to take a crack?
Yeah, no, I echo the comments. I tell you, what's interesting is that one of the things that I really liked is the idea, we've used internally at UC Davis this phenomenon of e-consults and trying to consult internally in the institution, and I think it's a fantastic idea. One of the things that we found, it's actually that extra hand outside of the typical session. The place where someone's struggling, they need a question answered, and they need to phone a friend. We were very much cognizant of that component, and typically for our ECHO program over the number of years, actually we've been very liberal with just giving our cell phones, and we've had it was really a homegrown, family-based, project. I mean, in essence, no one abused the time. And actually what I found most fascinating about it is I think that small inflection point, which is the most helpful between colleagues, was probably the most influential for us, actually, because it took the ECHO sessions and molded it into a place where they said, yes, we gathered some topics of what you were mentioning, but now I'm employing it. And I really need help. And those conversations were great. So we didn't, get in the tanning booth with big veneers and the Tony Robbins and act as the, coach. But we did act as a pain coach and kind of a nice place to walk along with them on difficult cases. I would say the other thing that we've employed that is unique, and it's interesting with the other groups, is to we also try to develop different options of making the environment much more interesting in terms of the education. So the teach back methods, audience response, we've dabbled with different aspects of the science of learning to make or continue to generate the enthusiasm for each session. It's tough. Every day, it could be a Tuesday, and it's a long day. How do we generate that enthusiasm, that zest for getting information out? So it's interesting to hear everybody's take on it. But
I think that's a couple of good points there about when we first started our ECHO, there was a big fear by a lot of our participants about are we, the panel, going to judge them that they did something wrong? And we kind of made it a policy at the start, and I trained our team that we were just going to try to be as non-judgmental as possible. You might be thinking, gosh, why the heck did you do this? But just to encourage people that it was going to be a learning environment, and that we were not going to be critical of mistakes that maybe had been made, but maybe how we could start to move forward. And I think that's maybe why we've seen a lot of growth over the last year or two, is because word has gotten out that I can take this case that I may have messed up on, and they're not going to be critical of my decisions. So I don't know if anybody else has had that experience.
No eye rolling.
Yeah, exactly.
That's a very, very important point. Primary care providers are, to some extent, used to being talked down to by specialists, and we can
Exactly.
smell it a mile away.
Yeah,
So you
Yeah,
really
yeah.
have to be gentle,
Yeah.
and you need to. And we actually coach our specialists
Yeah,
in that.
we've tried to be as, people to say, appreciate your experience or your and the way we direct some of the questions or comments to the staff is, you've had a lot of experience with this stuff. What do you think? And that just kind of gets that buy-in with that.
So I've got a question. Could echo exist without webcams?
I don't think, it's so much better when we have the video, just because you see their faces and you learn about the people, and it's just so much better. We, at the beginning of each of our sessions, people have their video turned off, because maybe they're having a sandwich or something, and we, at the beginning of the session, will say, if you can, please turn your video on so we can see your faces.
Right. Which gets to, I was kind of leading to this, because some people aren't really engaged when they are involved in the session. They may be told by their administrator at an FQ, there's a great opportunity here for some CME. They dial in, they've got their webcam turned off, they're doing work behind the scene. How do you overcome that?
Well, I say, I'll call their name and say, hey, well, let's see your face. Oh, turn your webcam on.
So, good. That's a great way.
Yeah, kind of stand in front of the class. No, I think for us, the audience response, and we've done a lot of questions that can be plugged into your cell phone. The other is we ask questions, but we formulate a way which it's inviting to kind of stimulate. We're okay with long pauses of awkward silence. And to actually do that, because it stimulates the learning environment. The other is actually posing the negative. That being said is, what do you think we should do? Maybe we should prescribe, 60 milligrams BID OxyContin. Or perhaps there's many other things that we should be considering. And so we give that pole position. And then teach back is one of the best phenomenons kind of in current medical education, where it's brief but high yield topics that can be learned at home if you got a chance. And then when you come to the session, you're just a little bit, it's like a teaser, or just a bit interested in the topic and learn something about it. And oftentimes that's been incredibly helpful. And so those are some of the strategies we've used.
Great. Thank you.
So I want to say something a little different.
Yeah.
I think there's no question that an engaged provider and an engaged group of providers on echo is the way to have a good echo session. But we have a challenge in that, there are thousands of primary care practices around the country, and not all of the and I believe every single primary care provider needs to participate and needs to learn this kind. I don't think you can just have a one expert in pain, because there's too many patients with pain. And so not every provider, not every practice can afford to have all of their providers attending a 2-hour or an hour and a half echo session. So I think we have to explore. I agree there's more value in taking part live and actively participating in echo, but I don't want to say that there's no value in attending passively or even asynchronously. So, Augie talked a little bit, and I did, about recording the sessions and listening to them in your car. I'm not ready to give up that recorded content and say it has no value. So if I could have one provider join live and 6 providers listen in afterwards in their car or something, I think there's value there too. And I think we have to think about that, because the single biggest challenge of replicating and spreading echo is time. Most providers out there are seeing patients and in a fee-for-service environment, and most CFOs hate it when we take them out of clinical time to sit in and listen to cases on echo. And we've never figured out a way to overcome that. Maybe The payment reform discussion tomorrow will help us with that. But until it does, there are too many providers who would love to join but can't. And so I think we have to think about ways to use the content that comes out of the ECHO session to reach a larger audience.
Great. So I was thinking about how to pose this, but I'll just throw this out. I would like you to go back to that light bulb moment when you first found out about ECHO and you realized that, hey, this is something maybe we should do. And then you go on, you search it online, and it talks about going down to Albuquerque for 3 days for the initial immersion training. So for people in the audience here, can you talk about those steps, those initial baby steps that you have to take, the immersion process, the value in that, and then bringing it home and then starting to operationalize it? You want to start?
Sure. Originally, our institution, our group, we had some form of a teleconference relationship with our Indian Health Services and treating some of our Native American population with physicians that were in rural areas. It didn't take shape. It wasn't formed into like what was technical ECHO, but it was an exposure to understanding a process in which we could use phoning a friend, a teleconference, that kind of process. We weren't foreign to it. But I think the experience was when we decided that we'd get involved with ECHO, the light bulb moment is when we realized that what was going on, of course, in the state of California, the lack of great pain education. And then the thought process that as a university, one of our missions at the University of California is to educate. So we felt it was incumbent upon us in our wheelhouse to kind of explore that option. Some of the things that we were interested in, and talking with Darren offline, that we do still struggle with, would be that buy-in and that uptake originally. So how do we create a curriculum that we wanted to have designed in such a way that is appealing, that has that appetite, that's brief but yet high yield and helpful? Lastly, what I would say, in struggling to develop that each year and to keep it relevant, I think that's it's important. There are some top Billboard hits topics that come up every year, but that was really an experience of learning with other ECHO programs, ourselves, and taking it from a page out of our own book. Lastly, what I would just to mention the comment previously, there is a push in California to look at certification processes that in some way uplift the workforce. There isn't enough psychiatrists to treat every patient, and I know Kaiser has entered into new train-the-trainer programs and certifying primary care doctors as behavioral health champions, and then giving a little push on the salary. And that's kind of a shift in the paradigm, and I think that might be one of the incentives. It's unclear, but.
Awesome.
Yeah, so
Go ahead, Derek.
my light bulb came literally in June, reading that paper in the New England Journal.
Right.
I remember sitting there reading it and saying something like, "Eureka, this is what we need." I was in New Mexico in August of the same year, and by December of that year, we had our ECHO up and running. And I think that for me, the easy part, almost like falling off a log, is finding experts who can lecture and talk about the specialty. There's plenty of experts out there, and we've been doing this for a long time. The hard part was finding a group of people and training them on how to make it, I don't want to say entertaining, but how to make it engaging and how to make it look good. The curriculum's easy, no offense, the curriculum's easy. The technology is ridiculous. You can click a link and do it on your phone. But making the session dynamic and engaging is the key. So Augie, how many times did I say it has to look like ESPN? It's got to look like ESPN. They've got to talk back and forth about the difference, about what's going on in the play. It's got to be engaging. It's got to be fast-paced. And one of the things that our faculty, and Bennett is a master at this, does is he works the table. You know, he listens to the case, but he's a master of ceremony. In addition to being brilliant, he's a master of ceremonies. So he gets the psychologist to contribute. Then he goes to the pharmacist, and they move it around. That stuff is harder, and I think ultimately probably as important as the brilliance of the faculty, because there's plenty of brilliant faculty who don't know how to deliver a good lecture or how to engage primary care providers. And so we're giving up our clinical time, we're giving up our lunch. You got to keep me engaged, otherwise you lose the effect and you go to sleep, and or you start doing your notes and things like that, and then you lose the impact of it. So I would focus most of my effort on making something compelling, making it look good. Even things like your backdrop and the way you're sitting and all of that is important. It seems silly, but I think hire somebody from the television industry to help design your echo, and that's probably as important as getting your faculty.
So as a corollary, and we're going to continue to hear your experiences too, but also think about when you build it, how did you get them to come? You know, it's the spokes, and you know, there's some echoes that I know of that are struggling to get attendance. You know, that they've got a great product, but you know, the word isn't out. And I thought about Sanjeev when he first got this going. He had to travel all over the state, I think, to get people to buy in on this idea. You guys aren't doing that. You're not traveling around over the road show to get people interested. So
No, but we have someone at the Missouri Telehealth Network who has access to database of physicians, and they're out. That's not a clinician, but it's somebody out there essentially recruiting people to join and advertising it and promoting it. And
is anyone incentivizing the PCPs or the mid-levels to participate?
well, we've had some conversations with administrators to discuss with them the importance of this, mainly from a risk management standpoint, improvement of care, quality of care, those types of things, and to say, you know, ours is only an hour every 2 weeks, and we purposely did it that way over the noon hour so that people could be there over their lunch break. And we'll see people come in a few minutes late from their morning clinic or whatever, but that was kind of an executive decision to do it, limit it to 1 hour so we get more people to join, because I know some of the echoes are 1.5 to 2 hours, and I just thought that was maybe a little too much, and so we kind of make it user-friendly from that standpoint. So then we were able to go to the CFO to say, hey, this is just over, they're going to be on lunch break anyway, and we're going to provide them CME, and this is going to help your clinic to do a better job at taking care of patients. So, and again, the same type of networking and off the visits with this, you know, communication with the administrators to let them know that the importance of this.
And so the administrators are not saying you're being pulled out of productivity. You got to work to make up.
They cannot
time.
say that to us because we found, just informally polled the clinics, and everyone took a lunch break from 12 to 1, had no patients scheduled from 12 to 1. And so there's no excuse here.
Yeah, good.
We found, I'm not sure if your group, and we do the same thing from 12 to 1. We found the same workflow issue, and it's also an hour. It's kind of like a bonsai tree. It's been pruned. We've had an hour and 20 minutes, and and this is pretty much the evolution, the Darwinian aspect of our program. It's been 60 minutes at lunch.
And it sounds like limiting it to your time zone is critical then too.
Yeah,
Even though you see that there are echoes that get people from across the nation, if you're going to do that, some are going to be at 9 o'clock in the morning and some are going to be 1 in the afternoon. So.
Yeah, our echoes are usually not, I mean, they sometimes span lunch in somebody's time zone, but we haven't been able to do them just during lunch, I think. And I think the pitfall you fall into when you do it over lunch is I've never met a primary care provider who finishes at noon. They tend to finish at 12:15 or 12:20, and so they're coming late, they're rushing to get through their patients. In some ways, I think that's the worst time to do it, but because you don't get your audience there on time. So there's no way to get around it. There's a real challenge in convincing in making it valuable for a primary care organization to allocate time to do this. And until we have a payment system, whatever it is, where there's incentive for the primary care, for the CFO has to have an incentive to want to do this. And right now, when our providers join and take better care of patients with pain and identify their behavioral health needs and prevent their emergency room visits and all of those things, somebody's benefiting, but it's not us. We're losing money every time we do it, and we're doing it because it's the right thing to do, but that needs to change before ECHO is going to be truly sustainable.
In a way, this panel is a little bit unusual in that 3 out of 4 of you are not academic centers, where you operate out of UC Davis. From my conversations with ECHO centers that are academic centers, they struggle too because it's essentially free faculty time where you're supposed to be either doing patient work or research or something of that nature. So wondering about that from an academic standpoint. How do you make the case to your leadership there?
Mm-hmm. Yeah, no, that's a really good point. I think, it's interesting the different models, actually. I mean, in the case for the academic center, academic centers are now pressured where there's more and more of a clinical pursuit and there's very little research. If there is research, there's industry-sponsored research, and a lot of people frown upon the mercenary aspect that they feel to industry-sponsored research. And so the question is, but the sole mission of most universities is still to educate, and the cornerstone, the pillar. So in order to make that plea, it's the suggestion that we're educating. And in University of California, the goal was to educate the citizens of California. So we've been lucky that that hasn't fallen on deaf ears and still maintains itself as an important aspect of the university. I will say, originally, enrollment was small, and ECHO seemed to be, which was okay with us. For the same reason, we were pooling faculty. Our neurosurgeon would come and give a talk, our neuroradiologist, how to read an MRI, and it's all free volunteerism. That said, small ECHO groups seem to me to be very successful. As our group grew, there's some, and I don't know if the group speaks to this, there's some asymptote or inflection point where things start to degrade. I'm not saying that the wheels fall off the bus, but there's at some point where there's a max number where things aren't as effective.
So that's a good question. Do you all limit the number of attendees that are calling in?
No.
No?
No,
Okay.
no, we haven't had that issue.
So it's not a technological issue either?
No, Zoom can take can take hundreds, so it's not a
Okay,
technical issue. I think it's more an issue of keeping your members engaged.
Yeah, the only
Because-
technical issue is that if you have more than, I think it's 20 or so, they're on different screens, and so you kind of forget about the people who are on the other screen, so you have
That's
to
true.
zip back through. And you don't have a list of attendees where you can start calling names or.
Yeah.
But if somebody does speak up and ask a question, their video will pop up.
Yeah. Yeah, I mean, that gets to how much of ECHO is passive and how much is active. I mean, I always wonder, I think I'd be interested in how many cases you guys do in a typical ECHO session. I mean, we're lucky if we get through 3.
We usually only do 1 or 2.
Right, so almost by the numbers, if you have 30 participants or 50 participants, most people aren't presenting on any degree, to any degree of a regular basis, and does that degrade? It gets to your question about, how many before you've degraded the experience. I'm not sure we know the answer to that yet.
Do you try to, so you've got, say, 30 that are regularly calling in, but only 2 keep presenting?
Yeah, we have
Is that an
problem.
issue?
We
Yeah.
definitely have that
Yeah.
problem. And so what we've done is I may offline contact one of our regular participants who maybe hasn't presented a case in a while and say, I know you probably have a case, why don't you do it? And most of the time they'll say yes, or they'll come up with something,
What's the average length of time that a PCP needs to prepare for a presentation?
I tell them all they have to do is just remember the patient.
Right, so it's not like a grand
there's no
rounds where you're doing
Well-
research and,
And that's,
But they think it is, and
Yeah.
so you do,
Yeah.
I know
Yeah, you really have to-
Bennett and Augie give, early on when somebody joins, they talk about, how to prepare a case and how not to. And there's a lot of reassurance. You're not presenting at grand rounds.
Yes.
Just come. We're not going to, we'll ask you questions to draw it out. It's not the Inquisition. But I think I've heard from primary care providers that there is a perceived barrier there, that they're embarrassed, they're afraid to present, all those sorts of things.
Yeah, that's
You got to
the
reassure
same
them.
thing. Yeah, so we're going to judge you on.
yeah, I mean, we all had the experience in residency where you're
Yeah.
just getting continually, degraded
Yeah.
in front of everybody.
Those specialists.
But one of the things that we try to do too is not just, a lot of our cases, most of our cases are these horrible situations and very difficult, tough cases. We encourage our providers with maybe a success successful case that they managed well, to let our other participants know how to manage a successful one at the primary care level. And so those are some of the more rewarding cases that we do, because kind of lets that person brag a little bit about maybe something they've learned in the ECHO, especially if somebody's been participating for a long time. But I'll, again, if we're maybe haven't gotten a case listed for this coming week, I might call somebody up and say, hey, just tell us about one of your success cases.
Right. So how often during a session have you guys been kind of humbled because it was the social worker who figured out the case?
Oh, never.
And
No, we encourage that. We in fact, we'll have.
well, what I mean, you've never been but they have figured out the case.
Yeah. Oh, I guess I
see.
misunderstood you, but we encourage the social workers, and we have a lot of LCSWs and psychologists, behavioral health consultants who participate, and we'll encourage them to present cases, and because we view ours as a multidisciplinary pain team, and they're part of that team, and we've even had some where I thought that their position was far better than the primary care doc in how the things are being managed, and I even sensed some tension between the two of them at that clinic, and it was up to me to sort of be the referee in some cases, and steer them towards the behavioral health consultant, because I thought that was the appropriate course of action.
And I think it was Bennett that brought up this morning too, have you ever spent a day in their shoes kind of question, which often leads to an answer for you too.
Yeah, because a lot of times they'll get, the patient is playing off one, the behavioral health versus the physician, and the behavioral health consultant is the one who maybe says, don't use opioids. I know this is a problem for you, but the physician may be pushing it. I don't know, do you have an example of that?
We've seen the same thing when the question was about, getting, I guess, embarrassed, but we would love to be embarrassed by, the medical student or the MA or whoever can come up with the answer in the room. And that does happen quite a bit. Once the students get more comfortable, you can tell they're more comfortable presenting and so on. We have a lot of nurse practitioner students in our echoes right now. And they'll come up with the answers. They may need to be pulled out a little bit, but there they are. A lot of times on the way Echo works, there's a chat function where people are piping in. You can see these little, and someone will throw out, amazingly good ideas, and we just read them. So it's everybody talking at once. That's the whole idea, is to create a community, a learning community. And any one of the Echo experts in our room may pipe up and have the most salient thing to say. So.
And if you have somebody that's really good, and maybe somebody, I haven't seen a comment from them in a while, I might call on them and say,
Absolutely.
You had something to say here. What do you want to talk about?
Yeah, we'll have them read it.
Yeah.
Exactly.
Yeah.
So most Echo hubs run time-limited sessions. They're 10 sessions, or I don't know how many you guys do, but it's not forever. And I'm curious, have you studied whether or not the learning community sustains and continues to communicate amongst themselves after the Echo part ends?
Yeah, we have not, and it's a big missing piece of information. First of all, how long do you need to participate before you've got it?
Right.
That varies. We tend to engage a site for a year, and then
So it's a year.
graduate to a new group, and you can become emeritus.
So 25 sessions, 26 sessions.
Yeah, but I don't know if a year is the right amount. We've had some that do 6 months. I don't think we yet know that, and I think we need to know that, because you want to drill down to the minimum necessary exposure because of the time commitment and all that. So I think it would be great to do some studies of post-Echo what happens, but at this point I don't think we know the answer.
Yeah, I think we've had some groups stuck with us for almost over 4 years, and I always kind of wonder, wow. And it's some of the same program, and it's very interesting to me, and I always wonder about it. But in the end, what I find is the cyber community it's this kind of interesting group dynamic where someone has been in the group for quite some time, and they act as a sounding board, and they're very receptive to other new groups. and certainly they offer a lot, especially when the questions come up. Some of them are able to answer questions, and it engenders a whole group discussion. So, yeah, we have a group at Santa Cruz County that's been with us every session. They don't miss for 4 years, and we do one session a week, and it's over 30 sessions, 36 sessions a year.
That's awesome. Great. So there have been some experiments about paying the presenters during the ECHO sessions, and I know that New Mexico tried that model. I don't know if they're still doing it, but I think it was Molina that had, maybe it was a contractual relationship with the state that said that they needed to pay the providers to participate, like $150 to present. And I've always wondered about that in terms of FQs, because most of the time that money is just going to go into general revenues and never gets back to the providers. So have you guys talked about that? Is that an interesting thing for you to think about? Is that being done anywhere?
We're not doing that, but
Anytime anybody wants to pay us more for anything we do, we're interested, but I don't think that model would work very well for pain echo anyway. I mean, partly because it's not, it almost overemphasizes the presenting the case part, which is important, but, you know, when you're participating in echo, you're gaining enormous amount and you're applying it to your cases. So I think the incentive needs to be more general, and it needs to incentivize taking part in echo, like joining echo, being a part of it, participating, and in terms of getting that money directly to the provider, the only way to do that really is to embed it in your performance incentive system if you have one. A lot of health centers have a productivity-based incentive. You can add incentives on for becoming a pain expert or something like that. But I think, yeah, there's really no other way to work it in to actually get it into the pocket of the participant. And I'm not even sure that's what we would want. But I think that Molina case actually got overturned, and they had to stop doing that for some compliance reason with CMS. There was something afoul with that. I don't remember what.
Yeah. So some echoes are completely free, some are subscription-based, and some have health plans helping to sustain the academic centers. And so I think, maybe David, you could speak about that, and Darren, you could speak about that too, just so that we can see different ways that these are funded.
Yeah, the initial funding mechanism was just through a grant. So we were able to sustain the program that way. And there was also discussion between the managed Medicaid products to actually, should they pay participants? Should they offer pizza or food at the lunch hours? Should there be incentives for presenting cases? We had a long form for presenting cases. We pruned that down into a very concise form that's very easily uploaded and quickly scanned in to present cases. So that tried to ameliorate that. In the end, once the grant ran out, the managed Medicaid products liked the idea and the thought in some of the rural communities, some of the benefits that many of us know well is that if you're in a rural community and you don't have a lot of guest lecturers coming to your location and you still have an enthusiasm and zest for learning, it brings something back to your work where it breaks up the day. And ECHO has a number of layers to it. That's one of them. And so the suggestion was that some places, the managed Medicaid products actually liked it and paid for it, and we created a contractual relationship per clinic, nothing exorbitant, just enough to cover largely the problematic, cumbersome CME costs that the UC tend to require. So
I think Centene's one of those participating plans.
Yeah, I mean, we feel a little bit like David and Goliath, the David part, I think, in trying to get funding to sustain our ECHO. Our original ECHO was funded by a grant, and we've been pretty nimble at getting more grants from different sources, but it's tough because when you're pursuing an ECHO grant, you're competing against UC Davis, you're competing against New Mexico, and a lot of times they beat the pants off us, and so it's been challenging, but we've been kind of nimble and creative in getting grants from different sources. We have grants from SAMHSA, grant from HRSA, but increasingly we've been focusing our sights on people like Centene, and actually the California Health and Wellness Plan, the Centene subsidiary in California, is funding us to offer ECHO to participating practices in California, and we see that as a positive step and as one of the ways forward to keep ECHO sustained. But you have to be creative, and you have to write a lot of grants, I think is the bottom line.
We actually were really fortunate in Missouri for a few years. We got an appropriation from the state legislature, so that helped fund our ECHO for about 2 or 3 years. We had a change in administration last year, and they're still very supportive of ECHO, but instead they now want to shift it to just part of the Medicaid dollars that are budgeted each year. So we've been really fortunate with support from the state government.
Awesome. Awesome. Well, I know there's some people in the audience that have questions. I think it's time to open it up. Gene?
11:15. I think so, yeah. I don't know the specifics.
Want to get in touch with a specialist, either because they ran out of time or they have another question, and how do you control that bombarding of calls to specialists or emails?
So you're talking about the ECHO specialist that, yeah. So she was asking about, for ECHO participants, they've got a post-session question. How do they get access to the ECHO specialist that they want to pose some questions to?
Yeah, I mean, I think the e-consult component of this is the answer to that. That having been said, I don't think we really haven't gotten bombarded by lots of questions afterwards. I think, but I think being able to provide access through e-consult is the way to parse those out and to bundle them up and so that you can answer them. But when we've done that, we've never gotten hammered by it. Just hasn't come up.
We have maybe 2 or 3 kind of trailing dialogues going on, maybe between the complementary alternative medicine person to help the student get find somebody in their area of Pueblo, Colorado, or something like that. Those kind of conversations continue almost after every ECHO, but it's not a bombardment. It's kind of a continuation, and that could be because of the e-consult. I don't know.
Well, we just use, as part of being on the expert panel, you have to have your email address available and phone number available, so if you get a call at any time, you're supposed to take it.
That doesn't happen much, or?
No.
Yeah.
But, I mean, occasionally it does.
That's our same experience. We offer our cell phones and the email, and it's like I mentioned earlier, it's never been, there's people that have used it, certainly, and actually those that have used it, like I mentioned, they kind of have been the same person, actually. I tend to find, and actually you feel it's kind of endearing because they're coming back to you, and actually they're getting extra learning by the mentorship, and it's not used as much as you would think.
So I have a question. PHI, have you ever had something happen, that dreaded moment where there was something shared or something that happened that, and what are the guardrails that you put around it to prevent that from happening?
Well, we've definitely had it happen accidentally. Somebody actually said the name of the patient or something like that on there.
Right.
And we have to kind of reprimand, don't, please stop, and then remind everyone, you send out an email the next day, you cannot share protected health information. And so I don't know if you guys have had that happen.
Never. We have a very robust process of scrubbing. So we do exchange clinical, the health center sends information about the case to Ben and his team in advance.
We've had it where the presenter said the name of, on the talk, not like
And they're forewarned, never do that. It's just, human error.
Trained and scrubbed. We haven't had it happen.
Yeah, and we have a process of scrubbing as well, but yet somehow, before it goes out to the group, we have received documents, not with the patient name, but there's some identifier, and then we have to somehow address to make sure that it's scrubbed and that the identifier is removed, and then, of course, it's shared with the group. So that in and of itself is a problem, but it's part of the nuance of having a safeguard of protecting it. before it goes to the group.
And to the same thing, I think it needs to be said that e-consults are scrubbed and anonymized too, correct? There's no
so
PHR.
our e-consult or clinical exchanges of information.
Oh, they are?
Totally, yeah,
Can,
different. So
can
we
the e-consult provider, the physician, get paid for that service?
Yes.
Not through billing, though.
Well, it depends. So there's a different answer for every
Yeah.
state, for every organization. We have
Okay.
IPAs that have capitated contracts that'll pay a per consult rate. We have payers that'll pay us. We can bill with a CPT code. The billing for e-consult is complicated and very much depends on the state and on the region and on the environment. But those are different. We have BAAs with everybody. We use a HIPAA compliant platform, and that's exchange of clinical information.
Okay.
And a formal consult note comes back that goes in the chart.
Okay. Good. Other questions?
Any plans to embed this knowledge base into the medical schools, into the mid-level schools, or?
Right. So basically changing medical school or nursing school curriculum. Yeah, the pain competencies, which you can certainly access at the UC Davis website, or just type in pain competencies. It's actually a great paper that was put in Pain Medicine. That type of philosophy is slowly percolating in many different institutions. And for the first time, I have to tell you, I mean, even though it's kind of like you're a prophet not in your own land, at UC Davis we have a robust pain medicine faculty, but it had never been adopted into our own medical school curriculum. And as of this year, we have a new chancellor and we're adopting a new pain curriculum. So that's actually astounding for us, and it's unique. Similarly in the nursing school, pre-licensure will take care of and will happen all the folks that are coming up. And then, of course, we have to address the folks that are actually out in the field and practicing now. So it is a two-pronged approach.
Gene?
How do you take care of the malpractice component of it? Have you gotten into a situation where somebody can actually say your recommendation backfired?
I can repeat the question. The question was whether there's ever been any malpractice related to a Project Echo case. We certainly haven't had one. It's considered an educational activity. I'm sure, our motto is anybody can be sued for anything at any time, so I'm sure someday there will be. I think similar with e-consults in that you're giving direct clinical consultation about a case. So the second part of the answer is we have lots of malpractice coverage as well to prepare ourselves for the day when that happens. But never happened.
Oh, please. Yeah. I was going to say, I haven't had that happen where there's been an issue, but we have had a unique, it was kind of enlightening for all of us. This was about 3 years ago, one of our ECHO lecturers or dynamic lecture speakers was a malpractice attorney, a firm that's their sole purpose and goal in life is that. And it was a very unique, enlightening experience. And actually, a lot of the ECHO participants were interested in documentation, the appropriate documentation or lack thereof. What does it mean? And it kind of entered into the risks-benefit equation, and certainly has served as another one of the many, lecture data points for ECHO.
Question?
Thanks so much for being here. I'm a PA, also a hospitalist here in town, and we're in the process of starting a hospital induction program for Richard. So I'm curious if there are specific echoes for hospitalists. I think that the patient population in the hospital setting is a bit unique compared to a lot of the PCP type stuff that's talked about here today. So I'm just wondering if there are echoes specific for hospitalists in that population.
I wouldn't see a problem. I mean, I don't see why they couldn't join.
Yeah, I want to ask Augie, do we have anybody on our buprenorphine echoes from a hospital setting? I don't think so, but I can't think of why they wouldn't be able to join or be learning the same sort of stuff. What do you think?
Absolutely, because of the same patient population. These are essentially the same patient population that you see in hospitals and the ER, and the recommendations are the same. So I think the learning is the same, no matter where you practice, and we cover some of the nuances for the patient population.
I think it'd be interesting. I'd love to have a hospitalist doing hospital induction on our regular buprenorphine echo, because I think primary care needs to hear what you're doing, and probably vice versa. So I actually think it would strengthen the experience.
Yeah, I don't think it's happening very many places.
So feel free to join.
Kimber.
I can't remember which one of you, well, thank you for being here also, it's a great conversation. I'm interested to see, and you may have already talked about it, have you tracked the results of echo projects in patient engagement, for example? So when you're talking about PCP who gains that, additional confidence in asking behavioral health related questions, and you identify that a potential substance use disorder concern is at hand. Have you tracked to see if they're actually engaging in that referral to the next service? And then the other part would be, or have you tracked to see if prescriber or provider behavior is changing, for example, with opioids?
And I just want to take a second. Kimberly Falkenburg is going to be speaking tomorrow. She is a peer support specialist, and I think the role that peer support plays in this whole ecosystem is going to be critical going forward. So get a chance to hear her work.
So we published a paper in Pain Medicine about 2-3 months ago that looked at that exact question, because what I said before, there's lots of evidence that Project Echo attendance improves your confidence, improves your knowledge, but if it really is doing what it's supposed to do, you want to see that it's having first of all, that it's impacting actual provider treatment and behaviors, and hopefully, ultimately, it's impacting patient outcomes as well. And I think that's kind of how we've approached it. There's a framework called Moore's Framework, which is an evaluation framework for educational interventions. And it starts by showing that people show up and attend, goes on to show that people feel more confident, that they like it, that they gain knowledge, ultimately that they change their practice, and that this translates into patient and community benefit. Those are the 7 steps. We've gotten up to step 4, and in the paper that's what we described. So, people attended, people liked it, people gained knowledge, people gained confidence. But what we showed by doing hundreds and hundreds of chart reviews of providers who had taken part in ECHO, compared to a group of providers who were similar who hadn't, that they were statistically more likely to refer to behavioral health, to refer to physical therapy. They had a lower rate of referral to surgical subspecialties, and their opioid prescribing declined compared to their colleagues that didn't. So it's the first attempt to try to start showing that some of those, and these were not in the patients they presented, this was in their entire panel of patients. So what we're trying to show is that what they're learning in ECHO is actually being applied in their entire panel. And so that was our attempt to at least to start to show that. And we need, more research to take it one step further and show that, like you said, did the patients attend? Did they actually get better? I think we're a long way from being able to do that, but that's the kind of research that we need.
That's a PCORI grant, the Patient-Centered Research Institute.
Yep.
That'll be coming.
We submitted it and they didn't fund it, remember?
That's right.
Yeah, we wrote a huge PCORI grant. We got
To get just that, patient-centered outcomes, how did
Yeah.
it look from the patient's perspective when people went through ECHO?
There's a lot of work left to be done in this whole area, isn't there?
Yeah, there is. And writing a PCORI grant is no easy task.
I was just going to add that one of the best reviews, and we're still working on our return on investment data for 4 years. It's kind of a long saga, but the partner in it was the managed Medicaid product. It was the leadership. They offered up a lot of interesting data points, and we worked in tandem to pull all that data from billing and coding. So some of the data points to answer your question was we were able, like I mentioned earlier, with Partnership Health and Bob Moore's group, look at new starts for opioids, how it was previously, the history of old data, and then look at how many new starts for opioid therapy was being provided. Certainly there was a precipitous decline. High dose opioids, certainly a reduction. Looking through chart review, they did a large swath cross-section and justification for stable high dose. So what's the reasoning and rationale to continue opioid therapy? And some of the requirements that regulators are looking at, if you are going to continue opioid therapy, what should be the language written in your note? And dose escalation, similarly. Lastly, what I thought was one of the more fascinating points is many people would diagnose back pain and just say back pain, and lumbago, extra cream cheese, a little bit of chives. That was kind of the idea. The thought process is with a lot of diagnosis, we would teach about sacroiliitis, how to diagnose sacroiliac joint dysfunction, facetogenic related pain. So the diagnosis started to change, and people were using a more sophisticated, nuanced diagnosis, which actually, when you think about it, changes the dynamic of how we practice. Actually, now your extra cream cheese bagel has now changed into something completely different. And that begets the excellent referring physician. I don't need to rely on opioid therapy or anything else. I'm actually referring this patient for a sacroiliac joint injection. And lastly, I would say many of the echo participants said, you know, Dave, I send my patient to a pain specialist in our community, and they come back on more opioids than what I sent them on. And the idea then was, please don't add opioids to my patient's, laundry list of medications. Just do this procedure because I want to evaluate it afterwards. I'm the expert asking for the procedure. So that's some of the nuanced data that came out of, so far that's coming out of our review.
Good. Janet?
So Darren, I love one of the quotes you made earlier was, we must fix the dysfunctional system. The echo is wonderful, but we still have some other systemic things there. I've heard a lot of wonderful discussion today about how you have integrated behavioral health with education, and I can see a lot of applications to what Project Echo provides to general primary care practices. A lot of primary care practices in the state, particularly in our rural areas, they don't have the other stuff. Like, they don't have any mental health specialists. And so it's nice that they have access to these other experts there on that are part of the faculty for ECHO, or potentially learning from other participants that are students like themselves. But I'm struggling myself with how we help physicians that don't have really any of those tools. Just for, they're now convinced, based on Project ECHO, that this patient should not be given narcotics or should be weaned off because they have a deep psychosocial need. So I guess my question is, have you utilized Project ECHO to expand on other integrated practices or other things like that?
And let me just introduce Janet for a second here. Janet Hurley runs an amazing clinical system in Northeast Texas and is the new president of the Texas Academy of Family Physicians.
No, I think it's a great question that we struggle with. Great, you've taught them all these wonderful things, and now you cut them loose and say good luck with that. I think there's several answers to it. The first answer is, I think if you've taught a primary care provider how to identify that the pain is coming from or that there's a relation with antecedent trauma, you've already done something good. Somebody said earlier that simply by ferreting that out, you've started the therapy. And if you've trained them on not using opioids, because that's not the appropriate, you've already done something. Most FQHCs have some behavioral health, even if it's just social work or something. And so, in my experience, even in the most resource-poor areas, there's at least some access. Not always, I understand that. And I think for those sites where there really is truly no access to behavioral health, I think we have to get creative with video telehealth, with more traditional telehealth concepts. There's even some do-it-yourself online pain CBT interventions that I've seen that you can refer your patients to, where they can engage online in ways. I think we have to get creative and build relationships with community organizations and such. There's no easy answer for that, but I think there's different strategies. But it starts with teaching and learning and understanding that it's a problem, and every site is different. One of the things that Bennett and the team do really well is identifying and understanding what the resources are that each of their presenters have, so they can give not a recommendation for something that's never going to happen, but something that's more realistic based on the resources at hand.
Yeah, that's one of the things we try to do too, is for our rural areas of the state of Missouri, we try to connect them with someone, and we kind of just take the same approach. If this patient comes in with a ruptured AAA, are you just going to ignore it, or what are you going to do with that patient? And so we don't have a vascular surgeon in town, so what do you do with that patient? So we try to connect them with whatever resources might be available, introduce them to other physicians or behavioral health providers that might be willing to see those patients, and just kind of do a little networking that's involved with that. So, and we found that some of our participants in the ECHO, they didn't know that they had behavioral health right down the street that was willing to see patients, but now they connected, so
Our networks of excellence.
that's right.
Any other questions? Well, great. I want to thank you guys. Excellent discussion. I've got a few things I just want to go over, some housekeeping things, a little bit of discussion for tomorrow. Remember, if you've got a parking form that you need to go and get that replaced, if you picked it up this morning, they weren't actually validated, so please take care of that. We've got a really exciting day tomorrow, and there's no way that we can top today, but we are going to compete at least. I think it's an amazing day. And it starts out with Corey Waller, who is coming to us from the Camden Coalition. About almost 8 or 9, 10 years ago now, there was an article that was published in the New Yorker, authored by Atul Gawande, and if you're not familiar with Atul Gawande, go back and read everything he's ever written in the New Yorker. But it was called The Hotspotters, and it was about Camden, New Jersey. And we are going to hear the experience that one of the poorest urban areas in the country got transformed through identifying where people were overutilizing healthcare and what were the social determinants of health and what's the ecosystem that you have to build around those kinds of settings in order to address what is often the key root causes of things like chronic pain and addiction. And we're going to hear a lot about adverse childhood events and childhood trauma and things like that too. We have got an experience that is going to be shared from Colorado where Fred Thomas will be talking about the experience of taking ECHO statewide in a 2-year period and how they were able to accomplish that. Then we're going to have some breakout sessions, and I think they're really going to be exciting. We've got a group here from Austin that have integrated physical health in a community health center with behavioral health from a local mental health authority to set up a medication-assisted therapy clinic in South Austin. It is in its early stages, but they've got some great ideas. And then we also have this idea of taking inpatient, starting the buprenorphine as an inpatient, and then transferring or transitioning it with a warm handoff to the team in the clinic that will take over for their care in an integrated fashion. Harm reduction. This is all about naloxone dispensing. It's hugely underutilized in this state. We've got to figure out how to break through that. We've got some experts that are running the initiatives here in Texas on that. We're going to hear about the role of the prescription monitoring program and how it is critical to identify those people that are on opioids or other prescription drugs that are not playing by the rules, they're shopping, and how to identify them and how do we then deal with them and not doing what is most commonly done, which is kicking them out of the practice, but helping to identify what are the ways that we can help these people and get them to the right care in the right care setting and help them in their progress towards healing. We're going to also be hearing about the role that hepatitis C plays in this whole environment and the role that injection drugs has played in the spread of hepatitis C. Specifically, we'll hear a lot of data about hep C in Texas, the intersection between chronic pain and substance use, and I'm real excited that Norman Buddy Sussman from Baylor is here to share their experience with their Project ECHO that's been doing great down there. And then we've got some icing on the cake. We've got a whole session on yoga therapy in treating chronic pain and some amazing clinical examples and some innovative approaches that I think should get you all thinking about there's a really great way to deal with chronic pain in using the tenets of yoga therapy. That will be repeated again in another whole 45-minute session, so you get your choice of 2 tomorrow morning. At lunch, we've got my boss, Dr. David Harmon, talking about alternative payment models and how we're going to really help to change the system by using a variety of these sort of new models that are out there, like episodes of care, bundled payments, shared savings, et cetera, and that we can see how we can start to pay for some of these services that aren't necessarily covered under Medicaid right now. We're going to hear about the role of mental health in chronic pain and substance use from a leader in the field that's going to be sharing some of their experience. Again, mentioned peer support and how critical that, I think, is in helping this population improve their health and improve their existence, as they go through the whole recovery. And then, how many people here know what EMDR is? Okay, a fair number. Eye movement desensitization and reprocessing has emerged as the best therapy for post-traumatic stress disorder, and it really plays a role also in treating chronic pain and substance use. And so we're going to be hearing from some of the leaders here in Texas on EMDR and the role that that might play. I think it's critical that we incorporate that into our thinking as we're dealing with this population. And then these 4 will be back up, and I have no idea how we'll get another 4 people up here on stage, but we're going to try to have 8 of our physician thought leaders here to get up and have a panel discussion about what we learned from all these 2 sessions. And then on Sunday, we've got the training session for those who signed up for it for buprenorphine waiver training, and that we've already got about 45 people signed up for that, so that's going to be exciting too. So we start at 8:30 tomorrow. There's a continental breakfast from 8 to 8:30. So we'll see you then, and have a great evening.